Hello everybody. Today we are going to discuss about ST elevation MI. So advances in the prevention, diagnosis and management of the patient with acute ST segment elevation myocardial infarction have led to reduction both in the incidence and the case fatality rates from this condition. So the rapid delivery of the reperfusion therapy is the cornerstone of the STEMI management. So regarding pathophysiology, the initial pathophysiologic event leading to STEMI usually is rupture or erosion of the lipid-rich atherosclerotic plaque. The atherosclerotic plaque is the vulnerable to rupture, tend to have dense lipid-rich core and thin protective fibrous cap, and is often not associated with the critical narrowing of the arterial lumen. So the molecular factors that regulate synthesis and the dissolution of the extracellular matrix appear to modulate the integrity of the protective fibrous cap. In unstable atherosclerotic lesion, inflammatory cells accumulate at the shoulder region of the plaque, release the proteinases that degrade the extracellular matrix and weaken the fibrous cap at this critical site. As well, other morphological findings associated with the rupture-prone plaque include adventitial inflammation, neovascularization, plaque hemorrhage, vessel remodeling with minimal luminal obstruction, and spotty pattern of the calcification. Following plaque rupture, the platelet adhere to the subendothelial collagen, 1 Willebrand factor or fibrinogen, and become activated by the various local mediators such as adenosine diphosphate, collagen, and thrombin. Activated platelet undergo conformational change and secrete the content of their alpha granule, promote vasoconstriction and the clot retraction. Activated platelet also express the glycoprotein 2b3A receptor in the increased number and with the greater binding affinity. Fibrinogen mediated cross-linking at this critical receptor leads to the platelet aggregation. And on the phospholipid surface of platelet membrane, prothrombin is converted to thrombin, catalyzing the conversion of fibrinogen to fibrin. The distinguishing feature of the platelet fibrin clot in the STEMI is that it typically completely occludes the epicardial coronary arteries, leading to the transluminal myocardial injury manifested by ST segment elevation on ECG. Despite similar initial pathophysiological feature, unstable angina and STEMI are infrequently associated with complete occlusion of culprit coronary artery and do not benefit from the fibrinolytic therapy. Without reperfusion therapy, most patients with the STEMI suffer transluminal infarction and evolve Q wave over the first few days after MI. Successful reperfusion therapy, however, may limit the necrosis to the subendocardial region and prevent the development of the Q waves. The distinction between Q waves and the non-Q wave MI can only be made retrospectively and thus is not useful for early patient management. Regarding diagnosis and the risk management, history and physical examination, the pain of acute MI is quantitatively similar to angina and is classically described as severe pressure pain in the mediastinum, often radiating to left arm, neck, and jaw. Associated symptoms include dyspnea, diaphoresis, nausea, vomiting, and weakness. In elderly female and those with diabetes, pain is often atypical and may not be present at all. Commonly, inferior STEMI presents with nausea, vagal symptoms rather than chest pain. Characterization of the quality of the pain may help to distinguish MI from other conditions that causes chest discomfort, such as aortic dissection, pulmonary embolism, pericarditis, gastrointestinal disorders such as cholecystitis and pepticles. Patients with the acute MI often appear pale and clammy. In many cases, there are obvious distress. Elderly patients, in particular, may be agitated and incoherent. In contrast, patients with the cardiogenic shock may be listless and confused. The objective of initial examination should be to rapidly narrow and differential diagnosis and assess the clinical stability of the patient. The focus examination can help to differentiate ischemia from conditions such as pneumothorax, pericarditis, aortic dissection, and cholecystitis. The concomitant conditions such as valvular heart disease, peripheral vascular disease, cerebrovascular disease may complicate patient management and can be rapidly detected by physical examination. The brief survey of signs of congestive heart failure should be performed. Cool extremities and the impaired mental status suggest the decreased tissue perfusion, whereas elevated JVP and RAIL suggest the elevated cardiac filling pressure. Finally, hemodynamic and the mechanical complication of acute MI can often be detected by careful attention to physical findings. So, myocardial infarction with normal coronary artery. Up to 5% of patients with ischemic symptom and troponin elevation, including those with ST segment elevation, may ultimately have MI with normal coronary artery on coronary angiogram. While Minoca is more common among those presenting with NSTEMI, there are several conditions that can present with STEMI ST segment elevation. Takotsubo cardiomyopathy is also common. This syndrome more commonly among elderly female and is typically precipitated by the acute emotional distress and non-cardiac medical illness. The chest pain associated with the anteroapical ST segment elevation, T-wave inversion, and is usually indistinguishable from evolving atrial infarct. The other less common condition include causing ST segment elevation include coronary vasospasm, coronary embolism, thrombosis, and spontaneous coronary artery dissection. ECG. Performance of 12-lead ECG in the pre-hospital setting allows the activation of the STEMI team prior to hospital arrival, significantly reducing the time to reperfusion and leading to improved mortality. The ST segment elevation of acute MI must be distinguished from the cause by pericarditis or even normally elderly repolarization variant. Ischemic ST segment elevation typically has convex configuration and is limited to selected ECG leads in coronary vascular distribution and is often associated with reciprocal ST segment depression. Diagnostic criteria in the absence of LPB are based on ST segment elevation at J point in two contiguous leads of more than 0.1 mm in all leads other than V2, V3. In V2, V3, more than 0.2 mm is required in male more than 40 years and more than 2.5 in male less than 40 years, more than 1.5 in female. So ST segment elevation in the right precordial lead, that is V1, V3 through V6, is moderately sensitive and specific of RV infarction. Reversible ischemic ST segment elevation is also seen with the coronary vasospasm. Pericarditis, on the other hand, is typically associated with diffuse ST elevation and depression of PR segment. The counter of elevated ST segment in the pericarditis and early repolarization variant is typically concave. LBP masks the ischemic ST segment elevation. A new LBB in the patient with the ischemic chest discomfort may suggest a large infarction, but given the lack of specificity, this is no longer considered semi-equivalent in isolation and necessitating planned emergent reperfusion therapy. It should be emphasized that acute STEMI leading to LBB requires a very large ischemic territory and would not be expected to be subtle clinical event. Old LBB and LBB of unknown age represent the diagnostic dilemma because most of these patients do not have ongoing transmural myocardial ischemia. The Garbosa ECG criteria are specific but very sensitive for masked STEMI. Among patients not meeting Garbosa criteria, emergent echocardiography, rapid testing of cardiac biomarker, and even emergent cardiac catheterization should be considered. So this is the ECG changes characteristic of the pericarditis, that is concave ST elevation is seen diffusely together with PR segment depression. Importantly, T waves are essentially normal. And another distinguishing feature of ST elevation myocardial infarction. So proposed diagnostic algorithm for suspected myocardial infarction and LBP. So suspected ACS and LBP. So we need to look for hemodynamic instability in the acute heart failure. If hemodynamic instability in the acute heart failure is present, then emergent reperfusion by PCA. Then we need to see if hemodynamic instability is not there, then we need to see the Garbosa criteria is meeting or not. If the Garbaza criteria is meeting, then it is a STEMI equivalent. If there is a Garbaza criteria is not meeting, then perform the bedside echocardiography and serial biomarker testing. Then classify if in on echo, then on echocardiogram, if there is a regional wall motion abnormality, then it is mass STEMI. And if serial biomarkers are elevated, then it could be NSTEMI or unstable angina. Cardiac biomarkers are more important for initial diagnosis of NSTEMI than STEMI. For patient with STEMI, cardiac markers measurement are used to confirm diagnosis of patient with equivalent ECG changes and may help to judge the prognosis. Patient with elevated cardiac troponin and BNP level prior to initiation of the reperfusion therapy, whether with fibrinolytic and PCM, are at higher risk for death and heart failure even after accounting for baseline variables such as infarct location and time to treatment. The peak level of troponin provides a crude estimation on infarct size. It should be noted that with successful reperfusion, although the total amount of biomarker release is reduced, the peak value may actually increase, and the earlier peak and the more rapid fall in the biomarker level. Information from the patient's clinical presentation and the physical examination are also very valuable for assessing patient's prognosis. Evidence for heart failure and hemodynamic stress at the time of presentation is weighted heavily in this assessment. For example, it is possible to use patient's age and the vital sign at presentation to rapidly and accurately obtain the preliminary estimate of short-term survival. Anterior infarct location, delays to therapy, and information regarding medical comorbidity offer additional prognostic information. As such, tools such as STEMI Risk Score for STEMI and the Global Registry of Acute Coronary Event model that integrate age, physical examination, ECG, and other clinical parameters such as serum creatinine provide very strong discrimination of short and long-term mortality risk and should be implemented using simple bedside calculation, handheld device, and web-based tools. Regarding reperfusion therapy, rapid provision of the reperfusion therapy is the primary treatment objective in patient presenting with STEMI. Both primary PCI and pharmacological reperfusion are accepted reperfusion strategies, with primary PCI being the preferred method of reperfusion when it can be performed in timely manner by experienced operators. Now, what constitutes optimal reperfusion? Every successful coronary reperfusion limits the infarct size and improves LV dysfunction and survival. These benefits are at least in part owing to the early restoration of antegrade flow in infarct-related artery. In retrospective analysis of 6 angiographic trials of different fibrinolytic regimen, patients who achieved normal antegrade flow in infarct-related artery had 30-day mortality rate of 3.6% versus 6.6% in patients with the slow antegrade flow and 9.5% in patients with the occluded artery. With primary PCI, normal epicardial blood flow is achieved in more than 90% of STEMI patients, in contrast to 50% with the fibrinolytic therapy. However, even among patients who achieve the TIMI grade 3 flow in infarct-related artery after reperfusion therapy, tissue-level perfusion may be inadequate. Using a number of different diagnostic tools, investigators have demonstrated that measures of tissue and microvascular perfusion provide prognostic information that is independent of TIMI flow grade. For example, Ito and colleagues using myocardial contrast echocardiography found impaired tissue and microvascular perfusion in approximately one-third of patients with TIMI grade 3 blood flow after primary PCI. These patients were at increased risk for development of heart failure and death. Microvascular dysfunction is thought to occur in setting of myocardial infarction as a result of distal embolization of the microthrombi, tissue inflammation from myocyte necrosis, and arterial spasm caused by tissue injury. Perhaps the most clinically relevant measure of tissue perfusion is simple bedside assessment of the degree of resolution of ST segment elevation on 12-lead ECG. A greater degree of the ST segment resolution are associated with improved infrapilated artery epicardial blood flow. Furthermore, patients who have normal epicardial blood flow but persistent ST segment elevation on 12-lead ECG after reperfusion have abnormal tissue and microvascular perfusion, which lead to poor recovery of infarct zone wall motion and higher rate of death and heart failure. As a result, ST segment resolution appear to integrate epicardial and myocardial reperfusion, and as such may actually provide more clinically useful assessment of reperfusion than coronary angiography. Regarding time to reperfusion, regardless of choice of reperfusion therapy, several common themes are evident. First, the benefit of reperfusion therapy are time dependent. Patients who are fibrinolytic therapy with 1 hour from onset of chest pain have approximately 50% reduction in mortality, where those presenting more than 12 hours of after onset of symptom derive little, if any, benefit. For each hour earlier that patient is treated with fibrinolytic, there is 1% decrease in mortality. Similarly, for primary PCI, reduction in the first medical contact to device time improve the outcome of study. Although the performance metrics like first medical contact to device have catalyzed the important quality improvement effort at institutional level after initial presentation, broader initiative at systemic level aimed at reducing total ischemic time have been equally important because total ischemic time is the principal determinant of the outcome. To this aim, both American College of Cardiology and American Heart Association have well-established system-wide initiative aimed at reducing both in-hospital and pre-hospital system efficiency in order to reduce the total ischemic time. For example, this American College of Cardiology Door to Balloon Alliance is the quality initiative that utilizes strategies that discriminate between hospital with short and long door to balloon time to successfully reduce the majority of participating hospitals door to balloon time to then contemporary component of early STEMI pre-hospital care, EMS personnel perform 12-lead ECG at the time of first medical contact, activation of catheterization lab prior to patient arrival, transport directly to PCI capable hospital for primary PCI in less than 90 minutes. Then in emergency department, medicine physician activates catheterization laboratory. A single call to central page operator activates the PCI system. Immediate transfer to PCI capable hospital for primary PCI. If first medical contact to device time is less than 120 minutes, if patient arrives at non-PCI capable center. Administered fibrinolytic therapy in less than 30 minutes at non-PCI capable hospital where anticipated first medical contact to delivery device time at PCI capable hospital was more than 120 minutes. Then cardiac catheterization lab, expectation that staff will arrive in catheterization laboratory within 20 to 30 minutes after being pitched. Thank you guys.